We have a virtual lecture, and to chair this session, let me cordially invite Dr. Suren De Silva and Dr. Kalana Parana Palliagurge on to stage. Over to our moderators to introduce the speaker.
So this will be the Watson effect on world urology. So to introduce the speaker, may I hand over the mic to Dr. Suren De Silva, past president of SLAUS.
It's truly an honor to introduce Mr. Graham Watson, senior consultant urologist based in Eastbourne. He's a giant in endourology, and his pioneering work in laser lithotripsy changed the energy mechanism used for stone fragmentation. Graham's connection with Sri Lanka started in 2008. Since then, he's been coming every year, and some years more than once a year, and he conducts a PCNL course which is tailored to the country's needs, using the local faculty, local adapted instruments, and it was a tremendous success. Graham took this training program to other countries as well, and he's trained African urologists in more than 15 states. He's had many accolades, and the most prestigious award given by the SIU in recognition of his training of urologists, he was given the award Albert Schweitzer International Award. Without further ado, I'd like to invite Professor Graham Watson to deliver his lecture.
Ladies and gentlemen, this is a recording because I can't be with you in person, to my great sorrow. I'm going to talk about the development of a laser to break up kidney stones. Now, in 1981, I was a registrar at the Institute of Urology, and I had the great fortune to work for John Wickham, who was a leading light in stone surgery at the time. And he said, "Graham, find a way of breaking up stones with lasers." So I went and, well, first of all, what is a laser? It stands for light amplification by stimulated emission of radiation. So it's light energy. The light has got an excellent beam quality, what they call collimated. It's coherent, which just means it's in step, and it's a single wavelength, which means that you can specify the action of the laser by choosing a wavelength which is absorbed by the target. So the first thing to do is to have some idea about the absorption of your target. So I got a spectrophotometer and I looked at the absorption spectrum of stones. And here we can see that we've got 100% and 0%. And you can see that the absorption in the ultraviolet is excellent, but it drops to very low when you get to the 1 micron stage, which is where the neodymium YAG works. There's an absorption in the 2 micron level and another absorption at 3 microns. And 2 microns, or 2,000 nanometers, is where the thulium laser here and the holmium laser here operate. The neodymium YAG, unfortunately, operates right here. And I'm going to talk about the pulse dye laser, which operates here. So I went to try all the medical lasers that I could get my hands on. The neodymium YAG laser, the argon laser. There were a few Q-switched neodymium YAG lasers, but I couldn't get them down a fiber. That's a quartz silica fiber to transmit the laser energy. And all I could do with these continuous wave lasers was heat the stone up and produce something like a mini volcano in the middle of the tissues, which was never going to be useful. Now, there'd been some work with Q-switch lasers being fired directly onto brass containers in which they locked stones and fragmented them. So there was just the inkling that if you pulse a laser, that you can get a different type of action with shock waves. So I was looking around, and I found a long-pulsed neodymium YAG laser, which could go down a fiber. And I found that this would work on black stones, but it's operating here. And black stones obviously have more absorption of light. The clear stones it had no effect on at all. But with the dark stones, I found that I could actually fragment them rather than heat them up using a pulsed laser. So I had the start of something. Now, I read in a magazine called Laser Focus about the development of pulsed dye lasers in Massachusetts, in the high-tech corridor around Boston, Massachusetts. So I went with a few stones and some fibers, some quartz silica fibers to transmit the laser. And I found that it was very promising. So I went to the Massachusetts General Hospital and negotiated a position there for a year. And I then brought my then pregnant wife and my youngest daughter over to the States, and we spent a year in the USA. And I made great progress with the pulse dye laser, and we had a laser which would break up stones without any thermal action. There'd be a flash of white light and a noise, and the stone would break. Very promising. So we tried this in the pig ureter and found that there was no damage to the ureter. And we had a device to break up stones. Now, the laser fiber was 200 microns. That's 1/5 of a millimeter in diameter. So much smaller than anything that was existing at the time. So we went round all the instrument manufacturers to try to get them to make an instrument that would be small enough. We were currently using 11 French instruments, and our stricture rate was 10%. That's 10% of people requiring surgical correction of the damage that we did. So bad early days. So we went to a number of famous manufacturers who all said, look, the market is too small. It's not going to be worth us making a scope just for your laser. You're only going to sell a few. So we went to a company called Reichert and asked them to make up a ureteroscope to our specifications. And we came up with something which was 6 French, half the size, basically. And here I've got one of these now defunct scopes, but we gave it 2 channels, one for the laser, one for irrigation, 2 completely separate channels in the tiniest diameter. This was a rather radical development because it was the first use of a fiber optic image bundle instead of rod lenses. And so any slight curvature didn't affect the vision. And we could slide this up ureters with the greatest of ease. I bought this home, the scope and the laser, and we set up a ureteroscopy service in London, and our stricture rate just disappeared, went from 10% to 0%. And for a few years, this was the way to go. Quite a number of these lasers were sold, quite a number of the ureteroscopes. But then, inevitably, there was development. And it was the development of the holmium laser, followed by the thulium laser. And also, all the major instrument manufacturers went over to fiber optic bundles, image bundles, and many of them with 2 instrument channels, copying our design. And so we were taken over. Now, let me tell you a few things about how the laser works. So the pulse dye laser. we would use 80 millijoule pulses in a 200 micron fiber, and we would put the pulse dye laser had a pulse duration of 1 microsecond. That's 1/1,000,000th of a second. If you put 80 millijoules into a millionth of a second, you get a peak power of 80,000 watts during that millionth of a second. You're also putting it into a 200 micron fiber, and the tip of that is only 3.14 times 10 to the minus 4 square centimeters. Tiny. So you're using all of the facilities, all the properties of a laser to deliver it into a tiny fiber optic transmitting fiber, the quartz silica fiber, and you get a peak power density at the tip of 2.58 times 10 to the 8 watts per square centimeter. So what is that? 2,058 million watts per centimeter squared. A phenomenal power density. Now, along came the holmium laser and the thulium laser, and along with the long pulse neodymium YAG laser that I talked about in the past, they've got something like 0.5 joules delivered in a period of 100 microseconds. So that's a peak power of 5,000 watts, rather less, and a peak power density of 1.59 times 10 to the 7 watts per square centimeter. So you put in something like 10 times as much energy, and you end up with something which is almost a tenth of the power density. What we found was that the way the pulse dye worked was by producing something called a plasma. And basically, there was sufficient power density when absorbed to remove electrons from the elements and vaporize some of it. And that would produce a flash with a shock wave. And it was this shock wave that would break up the stones. But the holmium laser and the thulium laser had properties which are rather more pleasant. Let's look at the pulse dye laser versus the holmium and the thulium. And the pulse dye laser does not have any risk to tissue. The holmium and the thulium do. There is a thermal risk to tissue. You have to use it with care, but nevertheless it's remarkably efficient. I've talked here about the filter affecting the view. You have to protect your eyesight by using a filter, and you have to filter out the wavelength you're using. We were using green light with the pulse dye laser, so we had to put in a filter accordingly, and that would interfere with the view, whereas with the holmium and the thulium, there's no such filter, and you're just basically using something equivalent to glass to look through, which protects your eyesight and doesn't affect the vision. Propulsion is very much greater with the pulse dye laser than with the holmium and the thulium laser. And finally, debulking. So the counter of damage to tissue is that with the holmium and the thulium, you're actually boiling away stone, and you debulk the stone, so a lot of the stone is actually vaporized. Now, I want to warn you all about the word dusting, because when people talk about dusting, actually what you're doing is controlled vaporization. The holmium and the thulium are absorbed immediately by the water surrounding the stone and by the stone itself, but you've got to keep that heat a little bit clear of the tissue and respect the fact that if there is steam and smoke, that is not going to insulate you against the heat so much. So use it with care. And what I would suggest is if you're treating a stone in the ureter, go for the center of the stone as much as possible. Try to fragment it and then remove the fragments. Don't try to reduce that stone too much before you remove the pieces. because the smaller the piece of stone, the less, the closer you are to having heat affecting the tissues, and that could end up with a stricture. But nevertheless, what we ended up doing was starting the ball rolling with miniaturization of ureteroscopy and making it easier and safer. Now I want to move on to just talk a bit about the interaction I've had myself in Sri Lanka. I moved from London and came down to Eastbourne, and one of my registrars was a Sri Lankan, and Suren De Silva worked with me for a year. In 2008, he came to one of our conferences, came up to me and said, would I like to come and train the Sri Lanka in percutaneous stone surgery? Now, Sri Lanka, as you know, well, I can't tell you Sri Lankans about this, but Sri Lanka is a place where there are a huge number of stones. And at the time, 2008, it was almost exclusively treatment by open stone surgery. So, yes, and a month later, I was in Sri Lanka and we started training. And with Suren's friend and partner, Srinath Chandrasekhara, we got treating large numbers of stones, and they took up the skills very quickly. But I was teaching the surgery prone and using the bullseye technique. The whole treatment of stones in Sri Lanka was so efficient, and there were so many of them, that I said to Srinath, can we put on courses in Sri Lanka and bring UK trainees to Sri Lanka and train them alongside Sri Lankan trainees? So we started doing that. And we brought in faculty. So there was Professor Kumar from Delhi, Professor Zhang Yi from Beijing, from Ahmedabad, Janek Desai. And they showed me their way of puncturing the kidney. And I evolved and adapted and developed a much better technique thanks to this international interaction. And armed with this, I then went on to teach in Africa, and I've now taught percutaneous stone surgery in 13 countries. And I basically got I got addicted to helping other nations develop their surgery because it was so good for my heart to do that. And very life-affirming and a wonderful thing to do. So my thanks to Sri Lanka for infecting me with this addiction. I have had a wonderful life as a result of it. Thank you and goodbye.
Before we wind up for lunch, actually, Mr. Watson has raised Sri Lankan urology to a next level. So that's why not only me, lot of his trainees who went to UK and after training came to Sri Lanka and become specialized urological surgeons are now in the world stage. So a personal note, so after seeing this, I can understand why he decided not to come to Sri Lanka. Actually, it really brought a tear to my eye. So before I become very emotional, so may I hand over the mic to the compeer.